Hey, what's up, everybody? Andy here with Nothing's Off the Table, and we have another great episode for you tonight. We are actually going to be doing this Facebook Live, which is pretty exciting, but if you're seeing this part, Facebook Live portion is over. Anyway, be sure to follow us on Nothing's Off the Table podcast Facebook page, so that way you can get the updates on when we're going live. We would like to tell you a little bit about our topic tonight. So our topic tonight is geared for the ladies, basically. And our topic tonight is it's on endometriosis. So endometriosis, I'm not an expert, however, it is a condition in which tissue similar to the lining inside of the woman's uterus is found outside of the uterus, which causes chronic inflammatory reaction. Our guest tonight is Dr. Leslye Green. She's a native of New Orleans, Louisiana. She completed her undergraduate at Southeastern Louisiana University, and she earned a dual degree, a master's in public health, and her doctorate of medicine from Tulane University. Initially, she decided she wanted to go into the family residency program, so she completed her residency in that, but that wasn't getting it for her. Her childhood dream was to become an obstetrician gynecologist. So she did that. She is certified by the American Board of Obstetrics and Gynecology. She is also active duty serving in the Navy, and she currently resides in around the Pensacola, Florida area. Anyway, so it is my extreme pleasure to bring to you this evening Dr. Leslye Green.
You're listening to Nothing's Off the Table, the podcast where nothing, well, almost nothing, is too taboo to discuss. On Nothing's Off the Table, we give anyone and everyone a say. We may not agree with or even like the topic, but we're happy to give you a voice, listen to your perspective, and maybe even offer our own. Nothing's Off the Table is a MadSiss Productions podcast. Find us on Facebook, Instagram, and on iTunes. Also, be sure to check out our sponsor, Locust Ridge LLC.
And we are live. Dr. Green, welcome to the show.
Thank you for having me.
Oh, I couldn't think of anyone better when this subject was suggested than my good friend, Dr. Green.
My favorite neighbor.
That's right. So, Dr. Green, you are a board-certified OBGYN doctor, correct?
Correct.
A prior family practice. So,
correct.
So you definitely got smart and got out of that field. Holy smokes.
It's a lot.
Yeah. So it was suggested that we do a topic on endometriosis. And real quick, I'm going to spout off my super, super limited knowledge on endometriosis. And then I'm sure you will correct me and tell me how foolish I am. So I see that it affects 1 in 10 women,
right,
especially during the reproductive years. And the symptoms are painful periods, painful ovulation, pain during or after intercourse, heavy bleeding, chronic pelvic pain, fatigue, and infertility, all of which I suffer with on a daily basis.
Exactly.
Yeah. So do they really know what causes this?
So there's a basic theory that's commonly accepted. So basically endometriosis, it's basically endometrium, which is the inside lining of the uterus that has gotten outside of the uterus. And so the most common theory is called Sampson's theory. The most common theory we have for the reason that this happens is called retrograde menstruation. So as opposed to that lining, building up and then going down and out, during your period, some of it kind of refluxes back out of the tubes. And then you have these endometrial cells that kind of stick to different parts of the lining of your belly and your pelvis.
Okay. So now, I'm not that smart of an individual. Maybe you could break that down a little bit better for the layman's
So let me see if I'm not sure how well this picture is going to show up for you, but I'm trying to get really, really close here. So here we have the uterus.
Okay.
And so everything should go down and out of the vagina and out of the body. But instead, it goes out of the fallopian tubes, and then you get some implants on the ovary, get these implants inside your belly, implants here onto your bowel and your colon. My husband even had to resect some from the belly button. Some get stuck onto your bladder. So instead of staying right here inside the uterus, you get all these little cells that are all outside of the uterus.
No wonder that causes pain. Now, for those that are joining us on Facebook right now, you're not going to be able to see what she's putting up, but that's okay. I'm recording this, and we'll put it up on the YouTube channel afterwards. So that's very interesting. I'm having a little technical difficulties getting Chad on. I don't know what's going on, but that's all right. We'll get him here in a minute. But anyway, so 1 in 10. So how many would you say that is? Just in the States alone, how many women are suffering from this?
Well, gosh, there's probably at least, a few 100,000 women that are commonly, complaining of this. Chronic pelvic pain in and of itself is probably the most common complaint that we see in the GYN office. And of course, abnormal bleeding patterns. And then people that have endometriosis can have both abnormal bleeding patterns as well as the chronic pelvic pain that goes with it.
So how debilitating can this be?
So everyone is different. And of course, it kind of depends on where these implants are located. So it can be pretty debilitating. When we actually operate and look at the implants and try to remove and treat the endometriosis implants, sometimes we actually see lots of disease, and the people or the women just aren't really experiencing a whole lot of pain from it. Whereas, smaller implants can still cause debilitating pain. So I say that to say that there's a method of staging endometriosis, but it does not directly kind of correlate with the pain syndrome that goes with it.
I see. I think, correct me if I'm wrong, I've heard that there has even been cases found as far as in the lungs. Right. Wow.
Yeah, thoracic endometriosis.
Oh
right.
My God. Now, what kind of symptoms would that bring along?
So that would be, chest pain with deep breath. Sometimes, as far as coughing up blood, it's very, very rare that's an issue. But that you would notice that you have those symptoms around the time of your menstrual cycle because it's still responsive to those cyclic hormones, and you're having these symptoms you're noticing, only, cyclic related.
Hey, I think Chad just finally, I think we hashed out the difficulties here. Chad, you there, buddy?
Yeah, I am. Are we doing this? We weren't doing it via Skype.
We were, but for whatever reason, yours says unavailable. I've tried several times to call you. But anyway, let me introduce you real quick. We've already started. Okay. But Dr. Green, this is my co-host, Chad. Dr.
Hi,
Green.
Chad.
Dr. Green, how are you?
Good. How are you?
Can you hear her at all or no?
No, not at all.
All right. Hey, do me a favor then. Go to the Facebook page and join the group, and you'll be able to hear everything.
Okay.
Little tough technical difficulties, but that's okay. So I've got a question, Dr. Green. Sam McDonald, who we had on the show last week, she has a question. Says chronic pelvic pain has been her issue for almost 4 ovulation/menstrual cycles. It's time for her annual PEP. I almost said mine. That's a whole different story. I realize I have many symptoms described, and I need to bring those up. Do I need to bring those up to her doctor?
Definitely. Please never, ever be afraid or ashamed or embarrassed to bring up anything to your doctor. The 4 walls of that exam room are sacred. So we don't want you to walk away feeling unsatisfied with your visit. So make sure, if this is what concerns you, and it's becoming, definitely if it's affecting your lifestyle, you need to definitely bring it up to your doctor.
Chronic pelvic pain.
We got a little bit of feedback going on there. I'm not sure where.
Now there's going to be a delay, man.
Yeah. So
I tell you what, I'm going to get mine sorted out, and I'm going to Skype you.
All right.
All right.
So excellent question, Sam, and thanks for bringing that up. Especially if you have Dr. Green as your doctor. So we have worked together kind of sorta in Japan when I was in the ER, and we would see her quite a bit when we would consult her. And the worst bedside manner ever. I mean, absolute best bedside manner. And obviously, I reached out to you, so you're one of my favorite OB docs ever, and
thank you.
Love working with you. And I couldn't think of anybody other that I would rather call for this topic than you.
I appreciate that.
Of course, I'll accept payment later. PayPal,
I got you.
Credit card,
Cash
whatever. So we talked about some of the signs and some of the symptoms. What are some of the treatment options for endometriosis?
So, some of the signs and symptoms, the bleeding and the pain. The treatment options range from taking non-steroidal anti-inflammatory medications because there's a significant portion of the endometriosis is related to this inflammatory response that the prostaglandin inhibition, or blocking the prostaglandins using the NSAIDs, can kind of help out with that pain. So that'll probably be the first recommendation. So especially if you have a very regular menstrual cycle where you can actually count out the days that you're going to, start to bleed. You, Andy, when you're going to count, you can count out the days.
Absolutely.
Then, about a half a day or a day before to start to pre-medicate with ibuprofen. If you buy the over-the-counter ibuprofen, they typically come in like a 200 milligram tablet. So you can take 2 of those every 4 hours, which is 400 milligrams. I say 4x4 or 6x6. So 400 milligrams every 4 hours or 600 milligrams every 6 hours. And start to take those the day before you anticipate your period, and then for up to 3 days. And then that can kind of help to curb some of the pain that's going to be associated with endometriosis-related pain. Of course, if that doesn't work, you can ask your doctor to prescribe other type of anti-inflammatory medications. There's celecoxib, or Celebrex is the brand name, or Movic brand name. Then I think the main thing that we prescribe in the first line would be some type of hormonal contraception.
Okay, that's what I was going to ask. Yeah.
Yeah. So that's the mainstay, and you can either take a cyclic version of a pill, and when I say cyclic, meaning that you take it every 3 weeks of active pills and then a week of bleeding, or you can take continuously take the active pills. And I say that when I describe it to patients as a treatment, not only does it decrease the quality of the pain, but it can also decrease the frequency of the pain because you're not having a period every month. You can, just kind of have a period 2 or 3 times a year. And so if you can kind of, pre-medicate and anticipate the pain, 2 or 3 times a year versus every 4 weeks, sometimes that helps the person's lifestyle.
Now, would Nexplanon or Depo be an option for this as well?
Well, yeah. So the better treatment modalities, the better treatment options to help treat endometriosis are ones that contain progesterone. Okay. And so the Nexplanon is a progesterone only hormonal contraceptive. Depo-Provera, same. The Mirena IUD works very well because it's acting, very directly on the endometrial lining. So those are great options.
What would be some of the potential side effects that someone would start that treatment that they could expect to see on those medications?
So one of the major side effects that happen with the progestins would be there's a little bit of weight gain, a little bit of bloating, a little bit of depression, and the unscheduled bleeding. I like to make sure that my patients, particularly with Nexplanon, I explain it's a 0.3% chance of getting pregnant. There's decrease of your pain with your endometriosis, but the bleeding pattern can be very unpredictable. Sometimes it's kind of gross to imagine if you were to include all of your 1 year's worth of menstrual blood into a bucket, you'd have the same amount. But with the Nexplanon, you can have a couple of drops here. You might skip a month. You might have a big, heavy period there. So the menstrual pattern, the flow is very unpredictable. And that's, common with any continuous progesterone therapy. The weight gain kind of increases your appetite. So I tell women to especially pay attention to the input versus the output, because when we actually study it, side by side, with the same, calories in, same calories out, weight loss can even happen. So it's pretty not that it's mostly just an appetite. So I tell patients that, if you notice you're going for seconds more than you used to, try to pay attention to that and make sure you maintain your physical activity. Depo-Provera would be notable for weight gain and depression as well. So if there's any particular, if you're prone to having the depression and anxiety, those are things to watch out for. Another thing that we counsel patients on that we put on Depo-Provera is that, especially our younger women, that there is reversible bone mineral loss. And so we try to make sure that they're taking a calcium and vitamin D supplement. Every woman of reproductive age should be on a prenatal vitamin, especially our younger women up to about age 21 should be taking extra calcium and vitamin D. Because believe it or not, your maximum calcium depositing into your bone happens, up to about 20 years old. So getting that calcium in now in your younger ages helps you out with osteoporosis later on.
Super important, absolutely. Sam has another question for you. I have a feeling that, Sam, you've got stuff written down, don't you? Probably so. Anyway, why does it seem like it's difficult for women to get diagnosed with endometriosis? She's read from friends and acquaintances where they've been experiencing symptoms for years before they were diagnosed correctly.
I can't, speak to everyone having issues. I know for myself, when I'm dealing with a patient, I start off with the same, methods that I talked about. It's using an anti-inflammatory medication like ibuprofen to start off in combination with the contraceptive hormones are the best first-line therapy. Most of us tend to try to just go ahead and treat. For one, it gets the patient relief sooner. Sure. And then we can save you the trip to the operating room. So if the medical therapy works for you, then you continue the medical therapy and don't have to go to the operating room. So if you've been on therapy for 6 months and still not getting adequate relief of your pain and symptoms, then it's definitely, something to consider going to the operating room. And so the gold standard, the way to diagnose endometriosis is to take a look at it, in surgery, and especially if you can actually biopsy it and send it to the pathologist and confirm that it's actually endometrial tissue that was found. So the goal of surgery is not that it completely treats your endometriosis and it's going to be gone forever, but you should think of it in the fact that if you've been on therapy for 6 months without relief, surgery can kind of help to decrease your burden of endometriosis, so to speak, so that the medical therapy can work better. So surgery to remove and treat as much endometriosis as we can find, and then to continue using the anti-inflammatory medicines and the contraceptive hormone medicines to help control the pain.
Excellent answer, which I expect nothing less. Sam, I hope that answered your question. Please let me know if it does not. Now, you keep mentioning going to the operating room. So what is that for biopsy type things, or is that for actual treatment?
It's for both. So the goal is it's for diagnosis and for treatment. Okay. So the best thing would be to do it laparoscopically. That is to put a camera inside into the belly button, commonly into the belly button for most GYN providers, unless there's a reason not to. But to go into the abdomen with a camera, inflate it with air so we can look around. We kind of have the patient in a slightly upside down position, so that kind of helps their GI tract, the colon and small bowel, to kind of move out of the way. We lift up their uterus. We look behind their ovaries. We look on top of the uterus. We look way down deep in what's called the cul-de-sac, this deep pocket behind the uterus. That's where most of it's found. We look all along the abdominal cavity. And so whenever we see something that looks suspicious for endometriosis, and it can come in various forms depending on how long it's been there. It can be powder burn lesions. It can be some white, scarish looking opaque tissue. It could be some windows, some tugging windows in your peritoneum. The lining of your abdomen can be some little blue blebs. So whenever we see anything that looks suspicious for endometriosis, we grab it and we biopsy it. We remove it, and then we take that out and we send it to the lab. Sometimes it's in locations that we cannot biopsy or we cannot treat, because the other treatment is to burn it. called to kind of to fulgurate or cauterize it. So the other treatment is to burn it. So sometimes it's in a location that's not safe for GYN providers to.
We're there.
Oh,
Sorry. Hello.
Sometimes it's in a position that's not safe for us to treat or remove. So if it's on top of the urine tubes, the ureters, for instance, I'm not going to touch that. If it's actually on the bowel, on the small intestine or the large intestine, the rectum, I'm not going to biopsy that because that's going to cause another complication for the patient on the bladder. And so in those cases, we kind of take a picture of it. And then we can refer them to a separate specialist to go and remove it from those organs that they deal with.
Oh my! Can you see Chad? Chad's there. Ooh.
I can see Chad.
Oh my Lord!
Sorry,
I don't know if that's a good thing or not.
So going in, and some people can just go in and take a picture of it and make the diagnosis, but the preferred thing is to biopsy it, to actually remove it, send it to the lab, and then treat.
Well, Sam said thank you. That was a wonderful information that you provided.
Awesome. I'm glad I could help, Sam.
Absolutely. Chad, we were talking about a subject that you suffer with. Endometriosis.
You look like you might be in pain.
I live in pain, and chances are I probably do suffer from it. I'm a medical miracle, quite honestly.
Anyway, so what's the worst, number one, the worst case of endometriosis that you personally have ever seen?
I haven't seen any really bad cases, recently. Some of the worst cases were probably during residency training when I was working with the reproductive endocrinologist and infertility specialist. Because, of course, infertility can be a complaint or a symptom related to endometriosis. And so when there's a stone wall of scar tissue that is built up behind the uterus, or large chocolate cysts, which are big cysts on the ovary that's kind of filled up with endometrial cells that are bleeding. So endometrioma or chocolate cysts. They've gotten to be pretty large, 4 or 5 centimeters, which is 5 inches, 3 to 4 inches or so. So, it can get pretty bad for some reason. And sometimes we find this unexpectedly, so we go into surgery. If we're looking for it, we'll find it probably in about, 60% of the patients that we assume have endometriosis. Other patients that have chronic pelvic pain, maybe 40% will actually say, okay, it's endometriosis that's causing your pain. But even when we're just going in for to tie your tubes or just to, look around for, something else, and happen to be about 8% will have some endometriosis implants that weren't causing any symptoms at all.
No kidding. So what type of surgery then would you do to correct it? I know we talked about going in for biopsy.
Right.
You wouldn't consider a hysterectomy or anything like that for this, or would you?
So it depends on where they are in their reproductive age. So if it's someone that's young and needs to maintain their fertility for in the future, then we would just try to go in and remove the endometriosis and burn it or fulgurate it. If they have lots of scar tissue, because sometimes the scar tissue that can develop from this inflammation can block their tubes, we can remove the scar tissue. That's called lysis of adhesions or adhesiolysis. We can remove the scar tissue. If there's a mass on their ovary or the chocolate cyst that I was talking about, we can remove the cyst from the ovary. So those are things that we can do. The definitive treatment to treat endometriosis for good would be completely removing the uterus, ovaries, and tubes.
I see. And that's not a very good. Let's just say that's not a very good option for a younger woman.
That's a last ditch effort.
That's the last ditch. It's some women, of course, for the most part, when there are other reasons for hysterectomy, we try to leave the ovaries behind because the ovaries are still, maintaining good function for you until most women, they cop out at about 51 and a half years old. And they still have a function for a lot of women up until about age 65 with, providing other hormones for you. So we like to leave the ovaries behind, but in women that have endometriosis, when we leave them behind, those implants of endometriosis are still there. The ovaries are still making the hormones, so it's still responding to those hormones. So in order to be completely rid of it, you have to take away the hormone producers.
That's craziness. What's I just lost my train of thought. Chad, bail me out, buddy. Just totally lost my
Hey,
train
man,
of thought.
we're talking about medical stuff. So unless we're talking about problems of the colon, I'm out. I got nothing for you.
Anyway, I know you went to Tulane and everything,
Yeah.
but got to fear the spear. Just saying. Yeah.
So, Florida State's garbage.
Just don't even start with me, pal.
No, seriously.
No, seriously.
Hey, I'm in the Panhandle, so I can't say too much about Florida State. So,
Are you in Pensacola or something right now?
right.
Nice.
Anyway, so I just
Lower Alabama.
yeah, exactly.
Yeah.
Just like to mention that I know we talked about it a little bit earlier, but so Dr. Green and I used to be neighbors in Japan. Just so you're
I heard that bit. I didn't hear that you were neighbors. I heard that you worked together.
Mhm.
You were blowing up her spot, which is weird because that's totally different than when you were telling me when she wasn't on the phone. But that's fine. That's all good,
Yeah.
right?
What can I do? What can I
But
say?
no, I didn't hear that you guys were neighbors.
And her husband is also a doctor, and he's probably one of them. Is he one of them Louisiana fellas too?
He is actually originally from Chicago.
Oh well, all right.
Yeah, so he's born in Chicago, but he grew up in Mississippi.
Mm-hmm.
Moved there when he was like 8 or 9.
So I know this is a little bit off topic, but so when we were getting ready to leave Japan, I don't know what I was thinking, but I let your husband talk me into going out with him. Oh my Lord, that was a night and a half.
You're still alive, Andy. You didn't die.
I don't know who drug who home that night. It was a wild night. I know I got in a lot of trouble for that one, but
You walking around on the haunch.
yeah, we were actually.
God.
Yeah. And we got home early though. We did. We came home early.
What, about 6 o'clock in the morning?
Yeah, right
Before
about
work
there.
started, right?
Yeah. So Connie wasn't too pleased with me. But,
I don't blame her. If I was Connie, I would be miserable with you pretty much all the time.
well, Dora wants to know where at Mississippi for Dallas.
So it's a little town right outside of Natchez called Fayette.
Never heard of it.
Exactly.
Yeah. Dora might have. She used to live down there, but yeah, I've never heard of it. Dora, do you have any specific questions other than where somebody from Mississippi, like anybody cares? I mean,
Mississippi.
But, Matt Smith Dr. Smith's from Mississippi. In fact, he's back there now. I don't know if you remember Matt Smith.
Oh, yes.
Yeah. Big corn-fed fella down in the ER. But, so he's in Mississippi right now, and he's actually contemplating a move, but he ended up getting out of the Navy.
Okay.
Yeah, but life's good. So I want to get back towards the medical side of the house, though. So we mentioned earlier that the symptoms, and it's much. How do I want to put this? It's highly advisable if you think you may have some of the symptoms, then of course you should make an appointment with your doctor. Correct.
Correct.
So is this one of the conditions that the treatment gets easier the sooner it's identified, or is it?
Yes, and definitely because the hormonal contraception, the way the progesterone works on the endometriosis implants is that it actually kind of helps to modify the tissue and shrink it. It kind of like women when they're pregnant, they have a history of endometriosis. When they're pregnant, they typically don't have their endometriosis pain syndrome. So what the contraceptives do is it kind of copies or mimics this pregnant-like state. So it modifies that endometrial tissue and even causes it to shrink and disappear.
Interesting. Wow. This is one of the areas that's why I'm glad you're on here, because I know so little about the OBGYN area.
You haven't spent much time as a woman, have you?
Well, it depends on the weekend, really, I guess.
Depends on who you ask.
It's a new Navy. I can identify however I want to.
Oh.
which I don't understand, because I'd rather identify as an admiral and get that pay than. But that's just me. No, I haven't spent much time as a woman lately. There was this one time. Never mind. That's a whole different department.
You know, quite honestly, I have a friend that she suffers from it, and it's borderline embarrassing because I don't really understand what it is. I mean, I know she's in a lot of pain all the time, but you know, I just nod my head. Hope you feel better. Kind of one of those deals, right? But I'm a moron, you know. So, anyways,
yeah.
So Andy, you are way ahead of me. Is my point.
The crickets were because nobody disagreed with you being a moron.
Yeah, no, I got it.
I'm not sure what Dora's trying to say yet. Dora says maybe she knows the city you're talking about.
Okay, she found it on the map.
I guess, or maybe she just, like I said, she lived down there, but I don't know. Anyway, so if you have questions and you want to talk to Dr. Green and specifically maybe get a voice answer instead of me trying to play the middleman, give us a call at 316-512-1465, and I have actually pinned it into the...
He just asked.
What's that now?
I said, Dallas just peeped in. I said,
did he?
You asked about him, so he's going to say hello.
Oh, he better come in here. Oh, look at this. What's up, my brother?
Hey, Andy Barker, what's going on?
What's going on, man? It's been a long time.
I know, you look good.
Oh, well, you ain't got a line to kick it. But
apparently y'all had a good night out on the town in the Hotch.
Oh, definitely.
From what I can remember, all I know is I got in a lot of trouble. Yeah, he bounced out real quick, didn't he? Yeah. Anyway.
On TV show.
He doesn't do lady parts.
That's not what I heard. But anyway. So do you ever have cases? I know we talked about, or you talked about specifically finding some of the tissues on the colon or the bladder. Is this something you would refer to Dallas? Is this in his neck of the woods?
That is in his neck of the woods. So cases that I have had to refer was a patient that just weirdly enough said that she has pain in her belly button every time with her menstrual cycle. And so just so happens that there was endometriosis there. And so Dallas went in and kind of just, I guess, removed it from her belly button and her pain got better. Had another patient that actually had to have a bowel resection. So she had to remove the section of her colon that was affected in order to get relief. And so you can just imagine every time, with your menstrual cycle, you get constipated, you have pain with your bowel movement. And with the bladder, every time your bladder fills, you feel the pain, especially around the time of your menstrual cycle. So you have this crampy, colicky pain along your flanks, if it's along your ureter. So if it's in those other places, those organs respond the same.
Dora.
I think we're getting a caller here.
Accept, press 1. To send a voice.
Dora, you there?
Yes, I am.
Hello there, stranger. So did you have a question for Dr. Green?
Hey, guys. Can you guys hear me?
Yes.
I think so. My cousin...
Hello.
Okay.
Oh, turn mute your screen.
Okay.
It's just like a radio show.
How's that?
Much better to me. Maybe not.
Okay.
I stand corrected.
Oh, I don't know.
Mute Facebook.
Okay.
Turn your volume all the way down.
How about now?
How about now?
Yeah.
That's better.
Yeah, it's better. Maybe not.
Okay.
We'll work with you. Go ahead.
Okay, my cousin had some serious pains every time she had her menstrual period, and her doctor gave her the solution of having a full hysterectomy. Is that always the case of something like that, to just go with a full hysterectomy?
So it depends on how old she is and where she is with childbearing. So that's the discussion we have with our patients, is that if you still want to have children in the future, we would try to do everything that we can medically possible to help relieve your symptoms. However, if you've been dealing with it for a while, the medical therapy isn't sufficient to to help you with relief. We've removed as much as we can. You don't plan on having any more kids, then the last ditch scenario would be to go ahead and remove the parts that are causing you the problems, and that would be the hysterectomy.
I think we lost her. I think we lost her, but that's okay. She should be able to pick up on that through the Facebook. Sam has another question for you. Sam's question is, what are common problems that endometriosis can mimic? For example, heartburn, constipation, etc.
Okay. So depends on where we have the endometriosis located. So it can mimic that you have a urinary tract infection. So if it's on the bladder, and it can also mimic you having a kidney stone. If it's along where your ureters are, it can mimic constipation when it's on your colon. It can mimic a bowel obstruction. It can also mimic asthma. It can mimic the hiccups if you have implants on your diaphragm. So those are different things, depending on where it's located, what kind of symptoms it's going to trigger in that area. If the endometriosis implants deeply enough, it can affect the actual nerve endings. That's part of the pain. It triggers those nerve endings to kind of fire in those areas.
That's an excellent question. Thanks, Sam. One that I'm not smart enough to come up with on my own, apparently. But that shouldn't fool anybody at all. Chad, don't say a word.
You said it all, man. What do you want me to say? Yes, I agree. You're a moron. I mean, what? How do you want me to do this?
Y'all are funny.
There's no love here, none. Wow. So, can you do a partial hysterectomy, or is this, like you said earlier, it still kind of leaves the hormones there to potentially come back?
Right. So it does leave the hormones to potentially come back. And I say that because when we do the hysterectomy, we will look for and try to remove everything that we can see. Mm-hmm. However, if there's some that's behind where the bowels are, and we don't see it, that can will still be left behind. If the ovaries are still there, they're going to still trigger a response.
Sure. I
will say this though, that if you do opt to have a complete hysterectomy. I say you, Andy.
Thank you.
If a woman opts to have a complete hysterectomy, including both ovaries, it is still okay to do hormone replacement or estrogen replacement therapy without triggering a response from endometriosis.
Well, I was just going to add in that it's too late for a hysterectomy for me because I'm married. So, Anyway, so what is the recovery time from a total hysterectomy?
It depends on the route of surgery. Most UINs will discuss that the best option would be to only have to do a vaginal hysterectomy, and that is to just be able to remove the uterus, through the vagina without making any abdominal incisions. However, someone with endometriosis, that's not the best option because we don't have an opportunity to look around to see, remove, treat any of the endometriosis implants. So if the reason for the hysterectomy is for endometriosis, it's going to most likely be laparoscopic. And so the recovery time, with that being a minimally invasive surgery, the recovery time is still pretty good. Most women feel like they can move a mountain in like 2 weeks. They should not, because your body is still healing.
Right.
So we recommend that they take off from work for 1 month. And there's pelvic rest, meaning no sex, no sexual intercourse, no toys, no tampons, no douching for 6 to 8 weeks.
Interesting. So when folks, some of the symptoms are painful intercourse. Now I'm completely ignorant to this, but what type of pain is this? And if it's after intercourse, how long would some of these symptoms last? Some patients.
That's a good question, because that's one of the common complaints with endometriosis, because that pain can occur anytime during the cycle. The dyspareunia, the pain with sexual intercourse, that can happen anytime during the cycle, and that's the result of the implants being along the ligaments of the pelvis. And so, just with the action of intercourse, That would be that's Morgan.
Hi, Morgan.
That newly grown woman you haven't seen in a while.
I have to see her again. Wait a minute. Tell her to come back here.
So just the action of the intercourse can put stress and strain on scar tissue that's down the pelvis, and that can cause pain. And typically it gets better, a few hours later. So taking some ibuprofen, rest. Unfortunately, a lot of people have to interrupt their sexual activity because the pain can be really unbearable for some women.
I can't even imagine. That's just going to be horrible. And I imagine that would probably impact the psyche as well.
It impacts a lot of stuff. And so it impacts the psyche, their mental well-being, just their interaction with each other. It can be a strain on the marriage. God bless the husbands that have, been really patient with some of my patients that have been dealing with, some of these symptoms.
Dora wants to know, can this cause someone to have a stroke?
So there is a small body of evidence related to the inflammatory mediators that are related to endometriosis that can also be related to the inflammation that can cause atherosclerosis and build up around the vessels. People that want to do some of the alternative therapies, or meaning diet modifications, increasing your omega-3 fatty acids does tend to decrease some of the symptoms associated with the pain. Increasing the fruit intake and green leafy vegetables can also affect that. Trying to think. So there was I don't want to say red meat, but another kind of a diet type change that can kind of affect some of the trans fats. Trans fats can also increase the symptoms of endometriosis. So that could go along with having some cardiovascular disease.
Now, what about the treatment as well? Are some of the birth control options or the hormones that you would prescribe, could they increase the risk of, say, cardiovascular disease, CVA, strokes?
So definitely in patients that are over age 35 and they have other cardiovascular risk factors, particularly our smokers, sometimes our diabetics, if you have uncontrolled high blood pressure, we don't want to add any combination therapies that include estrogen, especially. Because what estrogen does as well is that it goes, when you take it by mouth, it has to go to the liver to be processed.
Right.
And in doing that, it causes the liver to make more clotting factors. And if you're making more clotting factors, you're going to make more blood clots.
Sure.
And then that, causes, the heart attack and stroke. So if there are any other risk factors for cardiovascular disease, it should be used cautiously, the estrogen containing methods. However, the progesterone only methods like the IUD, the hormone releasing IUD, the implant in your arm, the shot, those do not have that effect because they don't contain estrogen.
Excellent. And that's also because it's not going through the first pass effect?
First pass, exactly.
Okay. Chad, this is probably the quietest and probably the most pleasant podcast we've had together.
Well, quite honestly, I'm just listening and I'm sitting there thinking about, some of the things you've said with regards to dietary concerns or restrictions. It's not really, I don't want to call it restrictions, but just dietary concerns. It is. So this is going to be a dumb question, and I have no shortage of dumb questions. So, what causes it?
What causes
endometriosis?
So endometriosis, there are multiple reasons that we've been considering. Part of it's genetic, predisposition.
Sure.
The most commonly accepted theory is that every month the inside lining of the uterus builds up, expecting a pregnancy. When one doesn't happen, that lining sheds, it goes down and out of the vagina. However, in some women, for whatever reason, this menstrual flow actually kind of goes retrograde out of the fallopian tubes, refluxes into the abdominal cavity outside of the uterus.
But it does it do that in response to something, some sort of stimulus, autoimmune type thing? Or, I mean,
So some of it's, like I said, some of it's a genetic predisposition. Some of it is just actually, in all honesty, this happens 90% of the time in well, most women. Most women just don't have these implants to actually take and stick and cause symptoms. So, but yeah, it's mostly genetic. There's some autoimmune factors, immunologic factors that can trigger it, or just even embryologically when you're still a fetus being developed. Some of the tissue that's supposed to go to one location just ends up in the wrong location, and that's how it started out in the wrong place. So,
well, and so here's what I'm wondering, right?
Okay.
So I could imagine like Dora's question about, her aunt, and I'm sure there's people that, hey, my aunt, my mom, my grandmother, whatever had it, so I'm going to get it, right? Are there things they can do to prevent that? How does somebody break the cycle? Can they? Or if it's going to happen to you, it's going to happen to you kind of gig?
Well, I don't want to doom women to thinking that, but I have to admit that there is, a hereditary factor there. There is a very common linkage that if you have female relatives with endometriosis, there's an increased chance of you developing endometriosis. Some of the things that a person can do to decrease their risk, or that we've known to decrease risk. If you think of it in a sense of if you can decrease your menstrual cycles. So if your first period starts late, that's fewer cycles that you're going to have. So people that have late onset of menses, if you're on birth control pills, that especially if you're on continuous methods, that decreases the number of menstrual cycles. If you're pregnant, so multi-parity, having a bunch of having babies, that decreases the number of menstrual cycles. So anytime you or breastfeeding, so anytime you can decrease the number of times that you have the opportunity for this menstrual flow to flow out, that decreases your chance of developing endometriosis.
That makes sense. Okay.
That brings up a thought in my mind when you say that. So we know that with a lot of our high caliber athletic women, that
I was just going to go there.
Yeah, great minds, right? High caliber athletic women, they don't have normal periods. Now, number one, does this bode well for them and their chances of never suffering from endometriosis? And number two, what's the percentage of the female athletes that you would actually see with endometriosis?
I mean, quite honestly, when you say that, it doesn't bear to mind that I have very many athletic women with that complaint so much. And so that also goes to aquatherapy, physical therapy. Being physically active also is a non-medical method for treating the pain.
Interesting. Sam has a question here, and I'm quoting exactly from her. I'm going to get personal here, sorry, Mom and Dad, and say that intercourse is pretty painful for her during ovulation. It feels like something is chipping away at her ovaries, and that was her first indication that she needs to talk to her doctor about a possible endometriosis diagnosis. Would you concur with that?
I would definitely agree. So it's both sides of that coin. It's very good in the sense that she does have, especially for women that are trying to get pregnant, to have that extra little signal that you're ovulating. But for women, some women, that's about a day and a half of some very crampy pain.
Mm-hmm. Interesting. Good question, Sam.
So again, the treatment would be a hormonal contraceptive that would decrease your ovulation. So thus, treating that pain.
Mm-hmm. Excellent. Yeah, that's geez. I can't imagine. There's so many times that I'm just glad I'm a man. Or half a man, or whatever. It doesn't matter.
You're a good man.
Well,
That's all that matters, Andy.
I appreciate that. And that means a lot coming from you.
Short, creepy man.
Well, I got nothing. What can I say?
Right.
So I want to actually Yeah, Sam says, I told you I'd have questions. Yes, you did, and yes, you do. And I love it. Keep them coming.
So I have one more question for you.
Sure.
Could things like not being able to, or it feels like not being able to completely evacuate your bladder, right?
Mm-hmm.
Things that, or night sweats, things that women might construe as menopause kind of stuff, are some of the things potentially could be related to endometriosis that are kind of disguised as something else?
Well, definitely if you're having difficulty in emptying the bladder, because it's like when you're pain with trying to urinate, could be related, especially if it's around that time of the month, could be related to endometriosis. I will say also, when you mentioned menopause, that's gloriously the end of endometriosis. But as you're in that phase, which for some women can be 5 or 7 year of irregular periods before they're finally done. And so with that, some women are ovulating more frequently. So that can also heighten the pain until they're done.
Interesting. So there is hope for women out there.
It's called pause.
Well, yeah, but I mean, if someone, there are lots of folks out there that are scared to death of going to the doctor, scared to death of medication, scared to death of surgery. So at least there is that hope.
Right.
I can't relate, but holy smokes.
And there's several, of course, they're all hormone related, but there are new medications coming out. There's the most recent one is a gonadotropin releasing antagonist that tends to help women out by kind of decreasing their estrogen production. It's good for them to use for up to about 2 years. Kind of gives them a break from the endometriosis pain. So there are new things that are coming out.
Speaking of all these hormones, I have a super inappropriate joke that I'm not going to tell because it's all right.
You know an inappropriate joke? Get out.
You can't set us up for the letdown.
All right. Well, I was trying to actually kind of sort of be serious on this podcast, but let me just go ahead and blow it.
Nothing's off the table.
That's right. Nothing's off the table. So speaking of all these hormones, do you know how to make a hormone? No. You give her $20. I warned you.
Oh my goodness.
The worst.
I couldn't resist. What can I say? Nora said, "Oh God." Sam gave a face plant emoji.
Oh my goodness.
I wouldn't be me.
Glad I have some ladies on the line.
Yeah, no, we do. We have some great listeners, some great friends, and I'm glad they accept me for who I am because I don't think I could change to set my ways.
Wouldn't want you to.
Thank you very much. As our president would say, nobody can be inappropriate as well as I can.
Oh my goodness, that's pretty good.
It's pretty scary, isn't it? I need to build a wall around myself. Anyway. Well, I think, Dora said, holy shit. Yeah, thank you. Thank you very little. Be sure to tip your waitresses and wait staff. Thank you. I'll be here all week. I think we have kept you on here quite a long time.
This is good stuff.
Yeah, it's great stuff. And if you're up for it, I would love to have you on like maybe once a month and we could cover a women's health topic.
Sure, sounds good to me. But I did want to just, throw out there, if anybody listening, if they want to, look up some more information, there's www.endometriosis.org.
I'm going to write that down.
Of course, the American College of Obstetrics and Gynecology, ACOG.org, and the specialists in endometriosis, the American Society for Reproductive Medicine, ASRM.org. So those are all great resources for information.
Andy, you got those to put them on the link?
Yeah. What was the first one again?
Endometriosis.org.
Oh, that
was the one that wasn't an acronym.
Yeah, that's why I couldn't write it down.
ACOG.org and ASRM.org.
Yes, I will put those up on the website, as well as when we put this on YouTube, I'll have the links up there as well, and in the comment section. So if anyone would like to do, like you said, and research the topic a little bit further.
And it's good to be an informed patient when you go in to talk to your doctor too.
Absolutely. That's why I have to have my grocery list of medications written down, because I forget everything. And that's a whole different topic. Dr. Green, thank you so much for being on the show.
You're welcome so much.
It was always...
It was a pleasure talking with you, Dr. Green.
Nice to meet you,
Sorry
Chad.
I was late. Nice to meet you.
And as always, you look stunning.
Thank you very much.
Dallas is a very lucky man. I don't think he realizes how lucky
I'll tell him you
he
said
is.
that.
You
Maybe
should.
if I come down to Pensacola for work, I'll stop in.
Hey, we're glad to have you. You got space.
Yeah.
Just tell him you're there for your appointment.
Right?
Yeah.
Oh, they believe it.
Yeah, they would. Give Dallas a big old hug for me, would you?
I sure will.
All right, guys, we're going to wrap it up here, and we'll see you on the next show.
All right. Have a good night.
You've been listening to Nothing's Off the Table, the podcast where no subject is too taboo to discuss. Find us on iTunes, Facebook, and on Instagram. Be sure to check out our sponsors, Locust Ridge LLC. Nothing's Off the Table is a MadSiss Productions podcast.